All right, feeling maybe a bit swamped with pediatric revision. Let's really focus in on one topic you are definitely going to come across.
Absolutely. Today we're getting into napkin rashes, clinically, diaper dermatitis.
Right.
And our plan is simple. Take those clinical overview notes you have and pull out the absolute must-know high-yield points. Really streamline your revision on this.
Okay, let's do it. So, starting simple, what exactly is a napkin rash?
It's basically skin irritation, inflammation,
Yeah.
specifically in the area covered by the diaper. That's why the term diaper dermatitis is, well, more precise.
Got it. Confined to that area. And frequency. How common are we talking?
Oh, incredibly common. You'll see this constantly. It affects infants all over the world. So yeah, you absolutely need to be comfortable managing it.
Okay, common. But why? What's actually causing it? Let's talk etiology, the risk factors.
Sure. It's usually a mix of things. Prolonged wetness is a big one, from urine, feces.
Makes sense.
Then there's friction, the diaper rubbing against the skin, and the irritants in the urine and stool themselves.
So the diaper environment itself is the main issue.
Pretty much. And critically, once that skin barrier gets damaged, you can get secondary problems.
Like infections.
Exactly. Fungal infections, especially Candida, are very common culprits. Sometimes bacterial ones, too. They complicate things.
So that barrier damage is key. What makes certain infants more prone to this?
Well, the risk factors link right back to those causes. Obviously, wearing diapers is the main one.
Yeah, right.
But also things like not changing the diaper often enough, maybe suboptimal hygiene if the baby has particularly sensitive skin.
Okay.
Also, episodes of diarrhea that increases moisture and irritation, and even antibiotic use.
How does that play in?
Antibiotics can disrupt the normal skin flora, the good bacteria, potentially letting fungi like Candida overgrow.
Right. Okay. So summing up the pathophysiology.
In a nutshell, moisture plus friction plus irritants equals a damaged skin barrier that leads to inflammation, redness, soreness, and potentially those secondary infections jumping in.
Okay, so it's not always just simple irritation. This is where differentiating comes in, right, for diagnosis. What are the key things we need to distinguish between?
Yes, this is crucial because it dictates treatment. The most frequent is that straightforward irritant dermatitis from wetness and waste.
Okay.
But you have to think about candidal dermatitis, fungal. And the classic sign, the thing to look for, is an erythematous rash, red rash, but with satellite lesions.
Satellite lesions, tell me more.
They're like little outlying spots, small red patches or pustules spreading out from the main affected area. Seeing those really points you towards Candida. It's a high-yield sign.
Got it. Satellite lesions, strongly a suspect Candida. What else might look similar?
Well, you could see seborrheic dermatitis down there. It's often red, maybe a bit flaky or greasy. You'd probably look for signs elsewhere, too, like cradle cap on the scalp. Psoriasis can sometimes appear in the diaper area, usually as sharply defined red, scaly patches. But again, you'd typically expect to see psoriasis elsewhere on the body.
Okay, so looking beyond the diaper is important?
Definitely. And atopic eczema, too, can affect the area, but usually you'll find it in the typical eczema spots, like the creases of elbows and knees. And always consider things like simple contact dermatitis from a wipe or cream or other skin infections, though they're less common.
All right, let's visualize the infants there. What are the actual clinical features? What are you seeing?
You'll see redness, obviously,
Yeah.
irritation. The rash itself in irritant dermatitis might have quite clear borders. Sometimes the skin looks soggy or softened from the moisture that's maceration.
Maceration.
You might see small raised bumps, papules, occasionally tiny blisters, vesicles, and then, of course, those satellite lesions if it's Candida.
And nailing down the cause. Do we need swabs, tests?
Usually, no. It's overwhelmingly a clinical diagnosis. You get the history, how long, any diarrhea, antibiotics, diapering routine, and then a careful look at the rash morphology. Are those satellite lesions present?
So investigations are rare.
Yeah, generally reserved for cases that just aren't getting better despite standard treatment or if it looks really unusual, atypical.
Makes sense. So you've assessed, you have a likely cause. How do we manage it? What's the approach?
Okay, management hinges on some core principles. First, the basics. Change diapers very frequently. Keep the area clean, gentle cleansing, maybe just water or mild, non-irritating wipes.
And dryness.
Crucial. Pat the area completely dry, maybe even some airtime. Let the skin breathe without a diaper for short periods. And avoid potential irritants like harsh soaps.
Right. What about creams?
Barrier creams are fundamental for simple irritant dermatitis. Things containing zinc oxide or zinc and castor oil. Apply a good thick layer at each change to protect the skin.
But you said treatment changes, Candida, for instance.
Yes, absolutely key point here. If you suspect Candida, you see those satellite lesions, a barrier cream alone won't cut it. You need an antifungal.
Which one?
Typically, a topical imidazole cream. Clotrimazole is common. Apply that directly to the rash. And this is important. You should actually stop using the thick barrier cream on the areas where you're putting the antifungal.
Oh, why is that?
The thick barrier might prevent the antifungal medicine from getting to the skin properly. You can still use barrier cream on the surrounding unaffected skin, but let the antifungal work directly on the rash.
That's a really vital, practical tip. Steroids. When do they come in?
Only for severe inflammation, and usually only if it's clearly not Candida or the Candida is being treated concurrently. And even then, it must be a mild steroid, specifically 1% hydrocortisone. Use it sparingly for a short time only.
Got it. Mild, short-term, and usually not if Candida is suspected. So overall outlook and potential problems.
The prognosis is generally very good. With the right approach identifying the cause, proper hygiene, appropriate cream, most rashes clear up within, a few days to maybe a couple of weeks.
And complications.
Mainly those secondary infections, bacterial or fungal, getting worse or causing delay, or the rash becoming chronic or keep coming back if the underlying factors aren't managed. And of course, it's uncomfortable for the baby. So, pulling it all together for your revision, we've covered what it is, why it happens, those key differentiating features, especially for Candida, and how that directly influences your management choices.
Which brings up a really practical thought. Think about how different the advice is. Barrier cream for irritation versus antifungal without barrier for Candida. Getting that diagnosis right, often just by looking closely for things like satellite lesions, is absolutely paramount. It's the difference between the rash clearing up quickly or potentially getting worse. It really highlights the importance of careful examination. Okay, that wraps up our high-yield deep dive into napkin rashes. We really hope breaking it down like this helps cement it in your mind.
And remember, for more resources tailored to your revision needs, do check out PassThemSRA.com and FreemSRA.com.